I'm going to speak about the Botswana Combination Prevention Project, TasP study. And as you know, there are many people in this room associated with the project, from the Ministry of Health, from Harvard School of Public Health, from BHP, from CDC, and from implementing partners such as Tabelo Pele, which HIV testing and counseling implementing partner. I will try to keep this brief because I know that many of you know quite a bit about the study. In fact, probably more than I do, because I've been in Botswana for 2 months and associated with the project for 6. But I will try to focus on what's different about this project from the others, and then I will give some general remarks about where we are likely to be, if we are fortunate, in 3 or 4 years or 5 years, and how we can prepare ourselves now for that. So the aims of the study, some of them are similar and some are a little different, but they are meant to look at whether or not enhanced combination prevention package can reduce population-level cumulative HIV incidence in Botswana, and to estimate the cost per additional HIV infected averted. There is a nested clinical trial in the study, the closed clinical cohort, which is Protocol 2. So this is a research study with 3 protocols, which is a new experience for me, and I think probably for many of us. And Protocol 2 is meant to compare clinical outcomes for initially ARV-naive, HIV-infected adults with CD4 greater than 350 and WHO stage 1 or 2 between study arms. And the study arms are those who receive what is currently available in the guidelines of the country of Botswana, which is antiretroviral therapy with CD4 less than 350 and WHO stage 3 or 4, or who receive antiretroviral therapy based on having a CD4 above 350, but having an HIV viral load above 10,000 copies, or being pregnant or breastfeeding. And the main clinical outcome to be compared is first occurrence of WHO stage 3 or 4 illness, major non-AIDS illness, or death from any cause. And Protocol 3, the intervention, is meant to assess the outcomes of ART for combination prevention in community residents not in the closed clinical cohort who start ART based on high viral load, or who continue following PMTCT, so option B+, and to estimate population level uptake of HIV testing, ART, male circumcision, and PMTCT services, and compare between communities. So the key features of the study: it is a pair-matched community randomized trial in 30 communities in Botswana. It has a set of interventions. We can go into the details. In total, it will cover about 180,000 people, and it has nested cohorts that will be of estimated 9,000 participants for the HIV incidence cohort and about 2,000 participants in the closed clinical cohort. So as you can see, the sites are paired, and randomization occurs immediately before the community. So we haven't randomized all the communities yet, but we have paired them. And the sites are spread across the country of Botswana. From what I'm told, not all the roads are as nice as they are here in Gaborone. Features that distinguish TasP study from other combination prevention and treatment as prevention protocols include treatment as prevention intervention above standard of care based on viral load greater than or equal to 10,000 copies, and additional incidence efficacy analysis based on viral phylogenetic linkage according to estimates for community of origin. So I won't go through in great detail the study design. It has a baseline household survey and HIV incidence cohorts. It has the nested clinical studies, and then has an end of study survey. It also has what we call the expanded treatment cohort, which will be people who will get antiretroviral therapy for high viral load or pregnancy or breastfeeding who are not part of the nested closed clinical cohort. And I just want to note that male circumcision, linkage to care, retention, and adherence support will be strengthened in the combination prevention community, so part of a combination intervention. In terms of laboratory components, because people have been asking, these are some of the things that will be done for the study. We are using PIMA for CD4 testing in the home. We're using viral load for monitoring, which is typically done in Botswana, but also for ART eligibility, which is not, and to look at sexual networks. And as I suspect many people involved in other studies are doing, we're also looking at HIV incidence using cross-sectional assays, in addition to longitudinal design. So the study's status and successes. The study was initiated in October 2013. We are currently in our second pair. We've completed the one-time activities in the first community pair, including the baseline household survey, the HIV testing and counseling, the clinical cohort enrollments, ART beyond country guidelines, and male circumcision activities. And we've been successful at engaging participants for all of these activities. The key challenges and issues, and I really appreciate the forum of this meeting and the chance to speak with other teams that are doing similar and also slightly different work and to learn from one another. We found a substantial proportion of residents not present at household visits, which has already been mentioned. We found higher than expected proportion of HIV-infected residents already on ART, and higher than expected proportion of known HIV positives accessing treatment outside of the study communities. I'm also finding that balancing the research study level of detail and accountability with large-scale implementation considerations, and doing so across multiple research and implementing partners really shows us how we're in the realm of both proof of concept and efficacy, but also effectiveness and all of the discussions that we have had today. So before I knew I was going to be presenting on the study, I was actually going to be presenting on where treatment as prevention fits into combination prevention. And so I took most of those slides out, and I promise not to take too much of your time, but I did have a couple slides that I wanted to discuss. One is about my conception of the public health perspective on treatment as prevention. And now I'm speaking as myself and not necessarily as anyone associated with any particular project. So each incident HIV case represents a tremendous long-term cost, social and financial, which could have been averted. I was fortunate to be part of the HPTN 052 team from when I was in Kenya, before I got here. And as everyone knows, HPTN 052 was a discordant couple study, but I don't think that that means that treatment as prevention is best understood as a couple's intervention per se. And I think this came up today from other discussions as well. So we know that within discordant couples, a lot of incident infections occur from outside the dyad. What we don't talk about, for example, with HPTN 052 very often, is the opposite, which is that we probably averted new cases among partners of the index who we never identified and weren't part of the study. And so to me, this argues that treatment as prevention really is a population level intervention, and seen that way, I think, is why we're here today. I also think that someone asked today if there are other diseases that we can use as a model for HIV, and I think of tuberculosis when I think about this, because a person with pulmonary tuberculosis in the community is contagious to others. And treating them is essentially treatment as prevention for tuberculosis. On the other hand, we know that treating people for TB in order to prevent new cases in the population can be difficult, and DOTS has been developed, and there have been issues with adherence to tuberculosis medications. And so there is a challenge that cuts across diseases about adherence as well. There's an efficiency that's inherent in focusing on the infected to protect the exposed. And this is where I know that we're going to have some discussion, I think, tomorrow about PrEP. And I think there's always a debate about, does it need to be treatment as prevention or PrEP or both? And I don't have the answer to that question. But in a place where, let's say you have 10% prevalence among sexually active adults of HIV, and if you have limited resources, and treatment can also protect the 90% by targeting the 10, that seems to me to be an efficient approach. Many of our discussions are grounded in resource constraints, and one of the questions that I have is how much that will have changed and how we could change that. So in terms of treatment as prevention, we know that it's a triple win. From what Wafa presented today, it's not 100% clear that there's a strong individual level benefit of earlier ART, but I do think most of us would agree it's not harmful. There's a prevention benefit and there's a potential cost benefit in the long run if we cross the tipping point. We are already benefiting from population level prevention treatments of benefits of ART as currently implemented. The question is sustainability, because essentially the way I think about it, the treatment programs that we have are also serving as a brake on the HIV infection. And if we threaten sustainability of ART, we're also threatening to take the brakes off, which I think most of us would agree would be a bad thing. So many of these issues have been raised, and I'll be brief. How can we optimally support people on ART who've never been ill with HIV? How can we reach those most in dire need and still manage to expand beyond that? And I think the data that Wafa, you showed about people with low CD4 being a source of many new infections is important. So we need to focus there clearly. There are always human rights considerations. Then again, every time we've expanded ART eligibility so far, people have shown up to take advantage of it. And in terms of optimizing implementation to maximize coverage, there are all of these issues that many of us are going to learn from the projects we're doing now about mobilization, education, uptake, saturation, and demand creation. So where we will be in the last 5 years, and I think SLIM is forcing us to think about this in the next 5 years, I should say, because we have a really complicated landscape of trials. And at the end of all of this, we're going to have to interpret that and turn it into something coherent. And each of us, I think, is interested in the subtleties of the differences between the designs. But then when we go to the policymakers and the politicians, they're going to want to know the bottom line. And so will we be able to untangle the relative contributions of different components of combination prevention and different designs? And will we need to? There's a role here for modeling and for other approaches. There will be inherent limitations. And I think that, as many have mentioned today, we should be thinking now about what smaller studies we should be doing in parallel, so that when we get to the end of these big studies, those can also inform how we move forward. So we don't find ourselves saying at the end of 5 years, if only we had also looked at how to make coverage better, not just try it and see that it doesn't reach very high levels. And then I think we have to challenge ourselves to develop rational policy and practices given the many approaches that we're now studying. We can take examples from male circumcision, where there were 3 different studies, different countries, different mature or not mature epidemics, different surgical techniques, different age groups of the populations. But in that case, we were fortunate that the finding came out very similar, and that was very intellectually satisfying. In other areas, such as PrEP and microbicides, we've had heterogeneity of results and challenges to understand where to take that. And I don't know where we will be in 4 or 5 years here, but given the complexity of even the studies, I think we can anticipate that we're going to have a lot to digest. I would also say one other thing is, PEP is an intervention that doesn't seem to be implemented very much, and yet we're talking about PrEP. I just wonder if other people also are interested to think about the PEP to PrEP transition. Because most people don't walk in and say, I might get exposed to HIV, I think I need PrEP, or I need a microbicide. They say, I got exposed to HIV and here I am. And if we're not implementing non-occupational PEP, then why would we implement PrEP? I think we probably should implement both potentially in the right circumstances, but I think we need to think of them together. So some final thoughts. Potentially biomedical tools can help us leapfrog some of these things. We're meeting here today in Africa. Africa doesn't have a functional landline telephone line system. And if we had tried to build one, we probably would have thought it was impossible. Luckily, mobile phones came along and we leapfrogged. Africa's never going to need to have landlines. And I think that there are things that biomedical interventions can bring us, potentially like long-acting antiretrovirals, which would decrease the burden on health systems, enhance adherence, could potentially be used both for treatment and pre-exposure prophylaxis. There are things like point-of-care testing. There are efficiencies in HIV testing and in delivery of treatment that all might help us to be able to actually sustain and implement the things that we're doing in these studies now. So, thank you for your time, and I look forward to further discussion.